We had started this on Sunday, people gave a feedback, it should happen on Saturday. We started on Saturday, it used to be 9 o'clock, people say it's too late, too early. We started 9:30, but Indian time. Then somebody said 10, now anyway, next meeting, they come or they don't come. Anyway, by lunch everybody will be in, so that we also understand. And there are annual paid members, they have not turned up. There are 35 of them. So probably, so anyway, so we will have this, and we have very good response even other places. They want to open up chapters, etc. And we have multifarious activities which is there already on the bookmark. We welcome you to be part of it. It was supposed to be last month. Though we have not publicized that way, but we have kept it purposely for 7th April being World Health Day today. And this magazine is also in that view. It is a health minister's interview in 6 pages who talks about what health would be, etc. Well, that is different, as most of the interviews of VIP is written, so that is also, it is written by that, but it is a health minister interview, whatever you may say so. We have been getting a feedback from people what we must have in this particular sessions, and accordingly we slate it. Last time was a business model. There were foreign faculty which came from Finland, and we take it to the level where it is required. This time we have started, we are having experts, and there are 2-3 presentations, but my request would be that let us be more interactive. And I think you can interrupt, discuss. Idea is to imbibe good practices, follow with each other, and see how we can do. If you see in the last page, we do bring out 2-page proceedings of last one which we have. Just turn more page, yeah. Okay, this is the club, this is of the last 2 pages. This is, we give the summary, what was discussed, etc. in the last time. So this also, we put it on YouTube, whatever you speak, for the benefit of others. We are talking about, for today's, my good friend Danny would be talking about the technical assessment, technological assessments. Well, it is started off that this was done along with the initially with the IIT Chennai, and they involved also to some extent to PHFI. It runs such kind of a training programs, etc. for 6 days. But then probably for some reason it did not take off after 2 years or so. Leadership change, or probably. We definitely going to introduce as one of the training, and we are doing training for cyber security for Ministry of Defense for full colonels and above. So these are the regular features. This will also put in. A good idea Dr. Ami was giving me. Anybody who have an expertise. Incidentally, the club activities are not for profit. It is registered as such under Section 8 company. So we are, as long as it is self-sustained to hire all this, etc., quite happy. So what we are trying to say that some of the training of a lower end will be in this, and some very higher end, because a resource person would require, will go on the other of the InnovatioCLUB, which is a profit arm. So anybody who have an idea, we can do this kind of a training for the benefit of everyone. Like she was telling me, patient engagement is another one. So any latest issues, concepts, this is your club, tell us, we will be only facilitating it, that's all. Well, we have lots of requests to start something in Bangalore, here and there. We have recently invited by Government of Gujarat, we have already signed up. They are creating creating an incubator in Surat, where as a part of the smart city, that is more important. At the city level they want to have this. and we will be running the health domain part of the incubator. So the government of Gujarat will give us an office in Surat, etc. Well, we are not from the diamond lobby, but any lady who wants to go and buy diamond, we can always accompany us, etc. I'll not take much time, and I will hand over. People will keep trickling in unless they have something else. And we will have Denny on the thing. He will introduce himself in a short, and then he will take it on. And we have already identified business model, which was last time, and same faculty is coming, and we are having on 4th of October as a pre-workshop of that. There is another person who is going to come where lean is my expertise. He's come from UK. We'll have 4th and 5th. So some of these training programs will be regularly done, and some will be as a part of the separate pre-workshop. So this is one, probably patient engagement or any such training program where people are benefited. We are not interested in show-sha, but where people are benefited. Thank you very much for coming on Saturday, so-called early morning, not for me, and Denny to take over. Thank you.
माइक से हो जाएगा.
Anybody who want to contribute for the magazine is most welcome. And we don't charge any money, we don't give money. We just contribute, and that's all. If it is for common good, we will always do so. Related to health innovation, directly, indirectly.
Okay, so I'll try to make your morning a bit useful and interesting. So I'm Denny John. I come from a clinical public health, health economics, epidemiology kind of background. I'm having a background in physiotherapy, but then I moved towards healthcare management, and my last degree was in health economics. I'm currently doing an external PhD in health technology assessment from Maastricht in Netherlands. And part of my work, I'm associated with an organization called Campbell Collaboration. If you're familiar with Cochrane, which is basically the evidence-based medicine unit, Campbell Collaboration is the sister organization of Cochrane, and we focus on evidence synthesis around public health and social aspects of in terms of health and education and other areas. I'm also attached as an adjunct scientist with the ICMR's institute called the National Institute of Medical Statistics, and where I provide both technical support and research, and also capacity building on 3 areas. One is evidence synthesis, essentially systematic reviews, and I'll give a brief on what is that method as part of that. Of course, economic evaluation in terms of cost effectiveness, cost benefit analysis, and finally health technology assessment. So that's primarily what my task is. When I looked at this topic, and I'm also part of the ministry's work on, and I will be explaining that in a bit. I thought of this topic when I started looking at the entire healthcare innovation, initiatives, or a lot of areas are, a lot of people are now either startups or they are initiating new ideas. So I'll be briefly talking about where does healthcare innovation and HTA fit, and then basically explain a bit about what is HTA, what is the process. I've been involved in a couple of activities, so I'll maybe make you go through that journey of what is HTA and what are the country level initiatives that's been done in India. And how can HTA be a part? I was just hearing the word patient engagement. How can you use patient or clinician engagement within health technology assessment? So how are those areas? How can you include those areas as part of the entire health HTA mechanism? So that would be the way that I'll speak, and feel free to interrupt or ask any questions as I go along. I have try to balance the technical and the general audience to some extent, so feel free to stop wherever it's becoming too complex. So nothing new. We are known as right from a Jugaad nation in terms of frugal innovation, especially frugal innovation, but also in otherwise that there are a lot of out-of-box innovations that are happening in healthcare in India, right? But what I started realizing when these innovations are happening, I think the major objective that we are all trying to achieve is, one is of course the coverage, that you're trying to reach a certain section of population which is currently not accessing either that type of healthcare, for example preventive. So you want a certain section of people to start using preventive, or you want to have another population which is basically maybe not fitting into the financial stream of the current either the public or the corporate kind of healthcare, and you want them to access, so you have a low cost kind of access. Or in many cases you're trying to have efficient ways of how a system can be managed or provided, right? So in all these areas there is some scope of looking at how HTA can be done. And my bump into the healthcare innovation happened because of this Bangalore based organization. I don't know how many of you are familiar with this company. This is called BEMPU. So what it does is, BEMPU is basically a company. So it basically has a wristband to be put on children who are basically prenatal babies who have a tendency for hypothermia, right? And basically this band picks up arterial hypoxia from these babies, and it becomes a different color which the mother can just identify and check. So initially you'll notice that the mother here is actually placing the baby on the chest, which is essentially known as kangaroo mother care. So she can basically understand when she should initiate kangaroo mother care, and in case this particular initiative, particular support is not able to give the baby that kind of heat transfer, then actually you can either it can reduce it, or if it still continues, the baby can be sent to the hospital or taken to the hospital. So the entire initiative of this band is to get a visual stimuli or a visual output for the mothers who traditionally would not know whether the baby is becoming hypoxic, or in many cases she would have ended up going far away from a rural place to a city and realized that there was actually no need for the baby to come to the hospital. She could have very well managed at home. So so currently this particular instrument has gone into all these kind of studies. So there is both a sensitivity and specificity done. There are case studies and there are trials which looked at whether it is effective compared to conventional or no care, or no instrument. But it has also gone into a reach of various states. If you notice, most of the states like Bangalore, that's because the organization is based out of there. But these are where the studies and evaluations are currently done. But if you look at all the studies, you don't find anywhere whether the entire instrument is effective, or is there a clinical effectiveness for that particular instrument compared to, say, the conventional care, because there's no clinical trial that they have done. They basically just done a comparative study. They have not covered whether this particular instrument saves money or is it cost effective compared to, say, nothing or any other alternative. And what will be the impact? For example, this particular instrument at current stage is 1200 rupees per baby. And once they reach up to a scale, the inventor mentioned to me that it can come up to 700. So the logic is that if I'm adding 700 rupees in addition to the entire maternity and the postnatal care of the baby, am I getting equivalent outcomes as well? Is it cost saving? And if that is not known as a system, because right now, if these states are going to pick it up, these are state governments who want to make a purchase. So they should understand, they should at least know, okay, I add this as part of my care. What is the additional budget that I need to spend? How many babies will be benefiting? And how many actually babies will be saved because if I pick these interventions, right? Now this is where the value of health technology assessment comes. And although I could explain them the value of this, we could not move forward. One, because the methodology requires some kind of rigor. and it requires some kind of understanding from the company also, that I want to understand this evidence as well.
One interruption. He is Professor Venkat. He is from IIM Lucknow, my good friend. Now, why I am interrupting it? He is one of the person of task force of UP.
Oh.
So I am discussing. Can we take it to you?
Okay.
Yeah, I am Lucknow.
Collaborators for
Yeah, okay.
Yeah.
Oh, okay.
So that is why I just thought I am.
The IAS officer is a very proactive man. And
Oh, okay.
he is
We'll-
going.
sure.
They have separate system. They have created separate unit where
Oh.
IS officer made as an MD.
So precisely Tamil Nadu model.
The same Tamil Nadu, Chhattisgarh model.
So we will do that. So don't worry, your things will not go away.
Okay. Anyway, so the background is where what I'm trying to say is that, and when I started, so this was the first time that I saw, this was someone, the people came to me because they came to know about my work and they met me in Delhi. But when I told them that what you're actually looking for in the terms of evidence are these three components, and currently none of your studies are actually looking at a randomized controlled trial or even a good controlled trials. I hope I'm not using vague terms or not. So basically clinical trials which are done in the field, not actually testing in the lab. But none of them are there. So I asked them questions that, have you checked your effectiveness on the field? How many people have actually benefited? Have you looked at the cost, additional cost? What do you do when you scale up? Will the cost come down? What is the cost of managing all that? Training also, right? You can't just expect a mother to put it, a rural mother, and put it and expect that she has to know how to use it. So what is the cost of training? They never had these answers. And I could not move forward with that group, right? So, and I thought that I am basing that as the foundation to start this dialogue, is just to explain that it is not rocket science, and I'm just trying to explain that now, although the group did not realize at that particular time how to take it forward. Now coming to a little bit, so basically trying to emphasize that even if an innovation is out, unless it's going to improve health outcomes, which is basically clinical effectiveness, if it's not going to be cost saving, or is it not going to be cost effective either when you do nothing or with current intervention, and what is the budget in terms of, either could be the household. If your consumer is going to purchase it, he should know, what is the impact on my budget to utilize that particular drug or a device, and what is the additional benefit that I'll get if I purchase that. It could be another, your consumer could also be an insurance company who's saying, yes, I want to include this as part of my reimbursement, and that is also required as evidence to show him, okay, what is the additional, okay, you spend this additional money on the patient, but these are the additional benefits that you get. And finally, to the government, most important thing is not, of course the first two is important, but they are large purchases. They would like to know what is the impact on my health budget if I adopt this particular new technology or new drug into my health system, and what happens to, because their coverage is much more higher. So these are the three bases on which the health technology assessment is focused. So if I just take a simple definition of, okay, and then I continue, or then that's all.
Go ahead, 11 you can, then they can have a cup of tea.
Okay. So I'll,
discussion.
yeah. So just to, and the reason I'm taking this slide is because just to highlight the fact that when we mean health technologies, it's not just the device or the technology that comes in. It can be anything that is related to promoting health. So it can be prevention program. Someone here was mentioning that the organization is focused on prevention. It can be also used for diagnosis or any kind of treatment. It can include all sorts of components like drugs, devices, any kind of procedure, any kind of organizational systems as well. So if you're including, say, a trained nurse to do an activity which would have been traditionally done by a clinician, that's also part of a technology input into the healthcare. And the reason I'm taking this particular definition is to explain that the health technology assessment is not about the assessment of technology. It's about any assessment of any inputs that goes into the healthcare provision or service delivery. Right? So basically it becomes, if I take a very technical definition, it is basically a systematic evaluation of the properties of a health technology, not only addressing the direct benefits in terms of its clinical effectiveness but also its intended effects, that what will be the future benefits or future effects of adopting that technology today. For example, screening. you're doing screening today so that morbidity or mortality of the population would be affected, say 5 years, 10 years down the line. So if you have to do cervical cancer screening today or a breast cancer screening today, you're actually anticipating that the incidence or burden of cancers would be lowered or minimized, and by that the overall cost of managing that disease would be minimized. Otherwise, why are you investing today, right? But not only that, those are intended effects, but also there are some indirect effects in terms of, if that money is saved, then you have households managing that, using that money for other purposes which could be more productive use, right? The middle class can use it for maybe improving their education and not trying to manage their healthcare expenses. But there could also be some unintended consequences that, okay, now I'm getting screened and I do screening every year regularly, then I'm also having a positive healthcare behavior as well. So that might not be the intention of screening, but that could become one of the unintended positive consequences of it. But the main essential thing is that it is a decision-making method, and that can be used by anyone who's trying to make a decision. It could be used by a clinician, it could be used by a program manager, it could be used by a government official, anyone, or even a hospital manager for that matter could use it. So essentially it is a decision-making tool, which is like a set of processes where you could use, where you can evaluate the properties of any new device, intervention, or any kind of organizational change that you're kind of making in a particular healthcare delivery system. Now, if I take this definition forward, what are the evidence, what are the components of HTA? The first thing is, of course, based on evidence-based practice. Those who are clinicians will realize that we are slowly moving towards a evidence-based medicine kind of area. But in healthcare delivery, you are talking not about one particular intervention. You are also talking about a series of components. So, for example, if I have to do cervical, if I'm doing, say, hypertension or blood diabetes screening, then I have to ensure that the follow-up care and the follow-up devices or any kind of interventions is also part of the evidence, and it's not just about screening, because screening is only one component of the entire care pathway. So that's one testing. So after the testing, there's a requirement that the drugs which are given should also be based on evidence, and it should be based on evidence-based practice. So the entire paradigm of evidence-based practice is based on what is called as a care pathway. And what is a care pathway is basically, for example, if you're screening a particular population or a people on, say, hypertension or diabetes, then you have to know which test is the most cost-effective method to identify whether the patient is diabetes or hypertension. After that, you have to ensure that the patients actually comply or even use the drugs, which are again based on evidence on effectiveness. If you're using them for, say, any other kind of a surgical procedure, even that is based on evidence. So it is not one singular decision, it's actually a care pathway. At every point you have to base it on evidence and not base it on just one person deciding what is the best way forward. So one is this, the principles will be based on evidence-based practice. Second would be a component called as health economic evaluation, where you kind of use principles of cost effectiveness or cost utility. Third is understanding policy or market analysis. For example, how many women require screening? What is the catchment population? What is the cost per screening? How many women do I need to screen? And then how many such centers do I need to build to screen that population, right? So these are kind of, second is somebody mentioned about patient engagement. Is the screening accepted by the community? Otherwise, even if you use a prevalence saying that yes, there is high prevalence, but if the acceptance is low, your screening is not going to be effective in the population. So other social factors, patient factors, cultural factors, these also social aspects, for example, these are all considerations under an HTA kind of a component. So essentially it is a context specific. So HTA done in Delhi population will not be relevant to Kerala population, will not be relevant to Chhattisgarh population, will not be relevant to UP population. And I'll give an example how India is moving towards a state specific HTA, although it started as a central initiative. But the objective is to go into a decision-making decision-making process, both at the policy, so that you decide cost-effective and evidence-based policies, but at the same time you have organizational processes which are also again based on evidence and cost-effectiveness at every level. So these are the HTA components, if I can just highlight it. And I'll try to give I'll split this into a few sections so that each step is understood. Who are the HTA stakeholders? Definitely the patients. And something that currently I'm co-guiding a student at University of Hyderabad, which is we are actually looking at how patients can be engaged in evaluation of technologies. That is something we don't actually value. We assume that, okay, we have tested a technology from a pure technical point of view and business point of view. We might even test it with, say, clinicians, but what about the patients, right? Are they also understanding, and have you checked their users? Have you asked them, is the design fine? Things like that. So there is this huge literature or body of work that's going to start, which is essentially called as patient engagement. In fact, in clinical trials in Europe, it's already started. But it's now going to slowly come into HTA as well, and we are kind of started using his PhD as a format to actually start looking at how can patient engagement factors be considered in Indian setting. Secondly, definitely the healthcare professionals, right? As a clinician, as a program manager, as somebody from, say, the health body, you would like to know, am I doing evidence-based practice? Is my hospital following evidence-based practice? Third is industry. Now, unfortunately, in India, the entire HTA is not regulated. That means it's not mandated that any drug or any device that's entering in India should be going through a health technology assessment process, right? All you have to do is you conduct your phase 3 trial in India, get the regulatory approval, and after that just get some licensing and your drug or device can enter. In fact, for device, now only the Device Act is in place, but for drugs, you need to go through all these processes. But if you take a government body like the UK or even half the European, half the Nordic countries, you have formal health technology assessment bodies. For example, in the UK, you have something called as a NICE. NICE is NICE, National Institute for Clinical and Healthcare Excellence. So what NICE does is, so if you are a pharmaceutical company and you want to introduce a drug in the UK, you have to first get what is called as a NICE approval. And there's a formal process in which you get that approval. This is not about efficacy trials and not even effectiveness trials. This is beyond, after, post, what is called as market access or post-market entry kind of mechanisms. You have to submit a full-page proposal to NICE. And then NICE assesses that drug or the device in the context of UK and then makes a positive or a negative or recommendation. Based on that recommendation is where the NHS, which is the National Health Service, accommodates that drug into the system. And then that drug gets part of the NHS and it is reimbursed or provided as part of the system. This is how a very formal, what is called as a formal health technology assessment functions. So for example, in the UK you have NICE, in Germany you have an organization called IQWIG or IQWIG for short. You have in Canada called as CADITH, CADTH, which is Canadian Agency for Drug and Technologies for Health. In New Zealand you have an organization called PharmAC, but in New Zealand it's called PharmAC because New Zealand only does for drugs and not for medical devices or programs. You have in Sweden called as SBU, the Swedish, it's a Swedish word, but anyway the short form is SBU. So these are, or in Denmark you have the Danish HTA. So these are formal HTA bodies which actually does the assessment for any new drug, technology or device, or even for the matter program. So if you're saying that this is what I want, this is a new preventive care method, or this is a new screening technology method I want to incorporate, then you have to go through that assessment by NICE, only then it gets incorporated by the NHS. So in India the industry requirements are still not there, but the reason I am focusing on healthcare innovations is the healthcare innovations are trying to establish a market and not like the drug companies where you already are kind of having some access, and how can this be useful to get your market is what I'm going to talk about. Fourth is third-party payers, the same issue. So for example, in Singapore, which has got a private insurance kind of a format, unless the Singapore agency, the HTA agency sets the benchmark that these are included, none of the insurance companies will reimburse that as part of the Singapore health system. In India, we don't have such. And we realized that when we were doing this research study, we realized that in medical devices, not just specific to cardiac stent, 90% of the devices come unregulated. There's no assessment. There's no formal assessment of any kind of devices that's happening in India. And even for that matter, when we looked at the cardiac stent specifically and we compared bare metal versus the evidence around drug-eluting, we realized that there is no evidence of any clinical effectiveness against both the stents. But unfortunately, when we looked at the evidence, none of those evidences was based on a low and middle income country setting. It was purely done most of the evidence that we picked up from clinical trials were focused more on high income countries. And in fact, there was no evidence to even show that bare metal, the DES was actually cost effective compared to bare metal. Now, when we look at that, then the insurance company should have been ideally looking at that evidence when they are making reimbursement, but they will just assume that both the stents are of equal effectiveness and cost, and I will look at the same. So we did try to take that effectiveness to J&J, and we tried to take that evidence to insurance companies, but they simply don't seem to understand how to place it in their entire reimbursement mechanism. Finally, the government, among all these, cloud of, I wouldn't say bad cloud, but the government seems to be a little bit ahead. The Department of Health Research has started this initiative, initially called the Medical Technology Assessment Board, which has now been rechristened into the Health Technology Assessment Initiative for India. And I'll be speaking a bit about that. So there is a government initiative that's already started, and where they've actually identified certain screening. There are certain programs that have identified, but they also identified certain devices like IOLs and stents and some drugs to actually go through an entire HTA process. So among all the components, I think the government is a little bit ahead in this case, where they've tried to push some HTA component as far as India is concerned. So if I take the first section on what is, it should be P and not M. So what is evidence-based practice or evidence-based medicine is basically where you are using the combination of having a clinical expertise, but also using the best research evidence along with patient values and preferences to make a clinical decision. For example, which drug should I use for a particular treatment, or what device should I use? So evidence-based practice moves around with that dimension. When I say evidence, the evidence will have all these kinds of hierarchies. Your top hierarchy would be definitely evidence from a meta-analysis or a synthesis of various studies, which essentially should be either randomized control kind of research studies. The reason that we say it should be randomized is you want the bias should be reduced as much as possible. There should not be any selection bias. You want a control so that you can compare the effects between the intervention versus the control group. And then all these other forms are at the next level of evidence. So the highest level of evidence will always be the systematic review kind of studies, which essentially focus on randomized control trials. Then you could have maybe one randomized control kind of study, which could be used one study if you don't have a multitude of studies around that topic. And then you could have a controlled research or a quasi-experimental. You can go into non-experimental, and then finally evidence from experts in clinical practice. If you look at India, the logic of evidence is reverse. The focus on the last component is more considered as evidence, and then it moves slowly upward with the last component using systematic reviews as part of your clinical practice to be the most minimal use of actually in clinical practice. So we are currently working on some clinical guidelines on OB obstetric and gynecology of India, and we analyzed around 30 guidelines, so-called guidelines in India, and right now we have identified around 8 or 9 where we are actually checking whether they have gone through a formal guideline development process. So I think in another 2 weeks we'll get that. But the value that I'm trying to say is that this is where the evidence should come, that it should not be from one clinical trial study but from a multitude of clinical trial studies, and then you assess the effectiveness around it. Now just to give an explanation, because I thought there could be some non-clinicians here or non-researchers, is what is evidence in everyday lives. So I've taken 2 examples, both from, so one is BBC saying, oh yeah, if you eat 7 times a day fruit and vegetable, it will save life. And then last year, Times of India had this article saying, oh, 7 is not enough, 10 is good. Now this is every day, so what do you base it on? So should I eat 7? Of course the question is, can I afford 10 times? That's a different story. But the question that I would ask is, okay, let me check whether it's based on what kind of evidence. So if I look at the first study, which looked at the 7P study, you'll notice that these are based on, so it basically tells me that those who are eating 7 and odd, about 7 kind of portions have a 42% chances of reduction of death in their cases, and it goes lower as the number of servings of fruit and vegetables come down. Whereas in the other, but the main issue with this study is that these are based on observational data. It's not based on a comparison group. For example, there is a lot of what is called as a selection bias. It could be because these people are actually more healthier anyway. They are using healthy practices, they're rich, so they can afford to eat the whole day. They have time to eat as well. So we don't know whether these are actually good control cases. So this is the issue of selection bias. Whereas in this case, this is actually again from an observational study, but it looked at a synthesis of almost 33 studies, again from observational studies only, right? But it looked at confounders, so it removed all the confounding elements. It looked at whether people are active, inactive, and tried to only isolate what is called as association. We have to understand that causality doesn't necessarily mean something like it associated. So we can say yes, tobacco is associated with lung cancer, but you cannot say all the time that actually smoking will cause lung cancer, because there are all other factors. So causality and association has to be understood. In this case, although this was from observational studies, the foundation was from a synthesis of 33 quality studies, but they isolated all the factors to actually say yes, there is some relationship of the consumption of fruit and vegetables, and it can reduce mortality.
If you have anything, kindly but
yeah, don't wait for it.
It's not a monologue.
Yeah. So that's the difference that you find here, right? And the value that I'm trying to say is that this is not like a clinical decision. This could be a personal, and this can come many times. I mean, the previous to this is actually a 5-piece versus 7-piece study, because WHO previously had suggested that 5 portions of fruit and vegetables per day is more useful. The same issue was there, that this will be based. Now the issue is not that, the issue is this: both these articles never mention about these factors from the research study. When I looked into the entire, and even BBC did not mention that. Even Times of India did not mention, because reporting of evidence is very weak. These guys should have said this is based on one single study, these were the issues, or this should be considered. And when you make these kind of statements, this particular article in Times of India should also have focused, yes, this was from a group of studies and not from a single study. Right? So we are also talking to some journalists who are health journalists and trying to say, how should you report evidence? Because these guys only highlight, say, a statement like this and never highlight from where this evidence is coming from. Is it coming from a single study? Is it coming from a pooled study or many studies? But what I'm trying to say is that the value of a pooled study would always be higher, even if there is a one single high quality study. So a pooled study will always have more, because of the more sample, you'll have more heterogeneity. For example, you could have more variations that you could check. So a pooling of studies, if done properly in a systematic manner, would always have more value than one single large study. right? And that is what I'm trying to show is the value of evidence-based practice. And I see a lot of these evaluations being done by one group and saying we did one study and we found positive change in people's behavior because of our preventive program. Try to check whether that evidence can be repeated again. Are you getting the same evidence? Then you can repeat it again, and then actually check, is it comparable to published studies as well, and then say yes, our program does seem to have an effect. But using one study from a program of 3 years and using a sample size of say even 2000 doesn't make any difference in terms of evidence, because all you are presenting is a before and after kind of a effect. And in preventive programs definitely there will be effect, because people were anyway not working, and that's the value of a preventive program. So we also need to understand how do we generate evidence and use that evidence for decision making. Now that's part of the evidence, right? That's how you use evidence. And so I'm going through a bit of understanding, and then I'll make you go through a case study which I was involved in. So I'll just throw that as a part to understand each step. Then comes what is called as a health economic evaluation, right? Where actually you look at what is the cost effectiveness or the cost utility or cost benefit of an intervention compared to zero, that is no intervention. So screening versus no screening, for example. Or you want to compare with say alternate intervention. So for example, are you going to look at vaccination for dengue, or do you want to invest more on vector-borne control measures, vector control measures? So you are comparing between one intervention versus an alternate intervention, and you are trying to understand what is the cost or the cost of putting that intervention, and what is the future benefit or what is the effectiveness of that intervention. But what is also important is to understand is, yes, you found it to be cost effective. Is it affordable by the country or by the people? So unless you do something like a budget impact to understand what is the impact of that technology or that program or that device in that population, this is usually done for a finite number of years. So budget impact is usually done for a 3-year period, and not a 5 or a 10-year kind of a projection. Essentially, those who know that.
I have a question.
Yeah.
I'm from Optimizer. We do a device like this which controls infection. I've done an HTA course with IIT Mumbai through Professor Dr. Jiten Sharma. What I feel is, this all looks great. What you're telling us is great. But what needs to be done is, the government and the people who actually do these studies should be put through this as a standard process, rather than just the example which you just gave us about 7 times or 10 times. So it's very misleading for the end person who reads it. So it's great that you're telling us, I do understand a lot of this, but at this moment, at this juncture, possibly at the end of your lecture, I would like to know as to what initiative has been taken to ensure that HTA becomes a standard by default process for all devices, if not for anything else.
Yes, so
what initiative has been taken by people like you who understand this so well in terms of enforcing, like we enforce so many more things? Because if you don't do an HTA study, I know it very, very well, that if you don't do an HT on a product, maybe you're just pushing the wrong cart.
Yeah.
So I think the initiative should go there more aggressively within the Ministry of Health.
Yeah, so that's why in the agenda I did mention that the last two or three slides I'll mention about what are the activities that the ministry is doing and what some of the agencies and including scientists at ICMR, whom I work very closely, are doing. So I have slides around that, and I'll be talking a bit because as one of the committee members I'm aware of what is happening inside the ministry as well. Yeah. So the important thing is, so what I want to summarize here is basically that establishing cost effectiveness alone will not be sufficient. You need to be talking about or looking at the impact, or the budget impact of that technology or the program or the device as well. And this is, I mean, those who have, and this is those who know the difference. I mean, some of you would be with economic evaluation tries to look at from an economic cost point of view. So it looks at economic cost, economic benefits, whereas the budget impact is more from a financial accounting perspective. So what is the cost that the organization or the intervention will be costing, and what is the cost of putting it on the ground, and what are the savings for the government or the insurer, saying that okay, this is the budget difference that I'll get. So this is the difference between this uses an economic principle and this uses a financial principle, and hence the need to see that a cost effectiveness alone is not sufficient. We should look at budget impact as well. Although in India you have to look at equity, and I'm not trying to focus that, but those who want some questions can ask in the end. Why? Because in India you cannot have cost effectiveness across the board. It has to be cost effective for all income categories. So it should be cost effective for the rural and well as urban. So we are, 12th of the next week I'll be talking at AIMS to look at how equity can be considered in cost effectiveness. So that's also another consideration at least countries like India should focus on. Anyway, so I'll just go through basics. The objective is to bring everybody to a same page and then take a case study and then explain what initiatives are being done, and then finally if there are any questions. So the economic evaluation is based on 3 areas, right? You have cost effectiveness, you have cost utility, and you have cost benefit. Cost effectiveness tries to look at what is the effectiveness and outcomes, cost of and both outcomes in both quantitative. But it essentially looks at a it's a non-monetary, but it looks at basically natural units of outcome. So it looks at what is the reduction of mortality, what is the reduction of number of bed days, number of length of stay reduced. So these are natural units which becomes your denominator. Whereas in cost utility analysis, you will have one single measure, either in the form of a QALY, which is quality adjusted life years, or it could be DALY, which is disability adjusted life years. So you are basically saying what is the cost per DALY saved or the cost per QALY gained because of one intervention, new intervention which you're suggesting compared to the previous intervention. So that is the value with one single outcome basis. The reason and cost utility is the standard for organizations like NICE and other organizations, because it becomes a single unit of measurement across all the decisions that they have to make. So even if you're doing, say, one, for example, for malaria, or for breast cancer, and you're comparing for, say, another technology, you can actually use the denominators as same. So it's actually considered a standard or a gold standard for formal HTA cost utility analysis considered. In India, we are moving towards it, but we are not using QALYs at present because India doesn't have a QALY measure as of now. We are still borrowing most of the utilities from European nations. We don't have utilities values which are very specific to Indian conditions. And hence in India, we are using a cost per DALY as a measure for measuring cost utility values. Finally is the cost benefit analysis, which basically tries to compare, okay, $1 invested, is the benefit more than $1 or a benefit less than $1? So basically you're trying to understand the difference, the effectiveness in terms of monetary benefits. The other two, just to give you a difference, in the other two methods, basically the denominator is more in the form of effectiveness outcomes. So it's a non-monetary outcome, whereas in the cost benefit is actually more like a monetary outcome. Message. Okay. So the quadrants are where basically you have 4 quadrants: southwest, northwest. So you basically, if any of your cost effectiveness intervention sits or this quadrant, then it is, it's acceptable. If this is where you have, this is where your benefit fits, you have to adopt, but this is where you have to reject. So basically this is where the cost effectiveness quadrants are used. A budget impact looks simple, not very complicated. It tries to look at the current environment and the new environment and what is the cost difference between both the interventions, and you kind of measure the budget impact on that. So in totality, just to give a difference, the results basically are both incremental for cost effectiveness is both the outcomes as well as the cost. Whereas in budget, it's purely just the incremental and the annual cost. So effectiveness is not part of any budget impact. You're only trying to say, okay, how much will be the additional money that the insurer or the patient or the company, or the government will have to spend if the new technology comes into place. So I'm just giving a case study. which I am involved in currently, we are at the third stage, we finished the first 2 work, is we know we were doing this study, and we started this study in 2013. We were trying to understand if what is the cost effectiveness of, say, the decentralized care versus centralized care for MDR TB in India. Decentralized care essentially means that the patient, once identified as MDR TB, after the window period of 6 months, essentially the basic 6 months treatment, he can go back home, and then the A&M or the worker can actually meet him at the home, or the person can come back to the facility, take treatment and go back. So that's like a decentralized ambulatory care model. Whereas in the centralized care model, the patient is actually admitted for till the time that he's actually either cured, or there's a failure, or there's a dropout or whatever. So we started with a systematic review. We identified these, but luckily when we started to look at a review, I found that there's already a review done, so we did not repeat the review. We looked at, and this particular study identified from a systematic review using around 35 observational studies. And in terms of the treatment success rate, if you look at the forest plot, this is a forest plot, this actually is almost 23 studies. You'll notice that in terms of success rate, the decentralized care model had higher success rate compared to a centralized care model. Including all unfavorable outcomes of death rate and failure rate and defaulter, decentralized care was found to be more effective compared to a centralized care model across some 13 publications. We looked at the review whether evidence is there on cost effectiveness. There were 3 studies which were already done. All the 3 studies showed that there is some kind of cost saving, or including effectiveness where decentralized care has been used. So we use those evidence to actually do this is accepted now, it will be published by June. And we did a study on India to actually look at is the decentralized care model for India cost effective, and if yes, what is the kind of cost savings that we are talking about, right? So we did a decision analytical model. So that's where the modeling comes. In health economic evaluation, you have to do modeling. And we did a model of using a decision tree. So this is what the model looks like, where the arm is between a decentralized care and decentralized care. And the outcomes was basically 4 outcomes. You had cure rate, failure, default, and mortality. And we compared between centralized care and decentralized care. So this was basically the cost benefit. So essentially you'll notice that a per case of $1,666 is saved per patient if the patient is treated under a decentralized care model compared to a centralized care model. And basically because the main drivers were actually hospitals. So even if you send the patient back home and he's traveling every month, we also included his travel cost or any travel of the worker. Even that for the next 18 months would be still less compared to the overall hospitalization cost. And this is a kind of a budget impact. So we did a scenario analysis on all the patients. So there were around, currently when we looked at 2016 data, we had 45,000 patients in MDR TB. So we looked at what is the savings across various proportion of patients if they are shifted to either decentralized care or centralized care. So this is the kind of proportion. So if 10% of the patients are in decentralized care and 90%, the cost savings are almost 94%. So as the proportion goes higher, but somewhere after 60-40, there is a negative. That means the decentralized care becomes actually more costly compared to the centralized care model. So this is where, and then we know this is the kind of cost saved per cured patient. This is the cost per death averted. So this is the kind of value that brings for. So we have now submitted this as a recommendation to the Ministry of Health, saying that this is the value that the universalization of actually the MDR TB. Although in India facility base is not focused so much, but we wanted to give evidence that your decentralized care would be saving so much money. Now you asked this question, so I'm focusing on that. So in India, there is a slight movement in the form of a Health Technology Assessment Board. It was initially announced in the 12th 5-year plan, but it took almost 2-3 years. So it was actually set up in 2015, but it got movement only early last year. It was initially called the Medical Technology Assessment Board, but now it's been rechristened into Health Technology Assessment in India. So it's a unit set under the Department of Health Research, and basically here the process is it identifies interventions in priority areas, picks up that, and then there is a structure like this. So there is a secretariat which is based under DHR. There is a technical appraisal committee which values what interventions are being done. There is a technical appraisal committee which assesses the technical partner document. So essentially what it means that, say Sri Chitra Tirunal in Trivandrum is one of the technical partners who would submit a, say, assessment back to on a particular topic that they have identified as a priority. The HTA will send it to the technical appraisal committee who would validate that. This should be actually, this is repeated twice. So anyway, there's only one. This, you can ignore this. So there is a technical appraisal committee which will appraise that particular methodology that is submitted by Sri Chitra. Because the secretariat cannot assess that. They are not a technical body. So they have identified a set of advisory board members which will validate the submissions given by these agencies. And these are right now, at least 9 interventions have been identified. And these interventions have been identified from Ministry of Health, RSBY, now it's been the National Health Protection Scheme and other areas which are given some priority topics, which then this particular evidence will be submitted to the Ministry of Health, and the Ministry of Health can then, it is just to give a difference between the NICE model or the European model and the India model is that this is not a compulsory recommendation. What it means, a compulsory recommendation is that if, for example, this body says this particular IOL or this particular stent is cost effective compared to the other stents, the other organizations are not bound to accept that. So it is just a voluntary recommendation. Organizations can accept it or not accept it. It is not, but in the UK kind of a setup, it is compulsory. So all the organizations who are putting IOL can only use that particular IOL or a stent, whereas in India that kind of compulsory recommendation has not yet come. So just a small difference. These are some of the objectives of that organization. So now there are these three. This was done under the Department of Health Research. National Institute of Medical Statistics is one of the technical bodies from ICMR who's supporting this initiative. So my affiliation as adjunct scientist also puts me into those committees. The Delhi, what we have also slowly started to recommend and it's accepted finally, that your states have become decentralized and health is a state subject. So choosing which is most cost effective should be left to the state and not to the center. And hence for this, there are these state units that have been established. These are called as state HTA bodies. And currently Kerala, it's Sri Chitra, Tamil Nadu, the National Institute of Research in Tuberculosis. And just yesterday, an MOU was signed at Kalam Institute of Health Technology, which will be the HTA body for Andhra Pradesh. The objective is the states, so for example, if his SIRS unit is looking at a drug as a purchase for UP, and in future this HTA body is in the UP, then the drugs that has to be procured by his unit will go through the HTA for approval, and only then they can procure those drugs into the medical corporation. That is the logic of the entire HTA. It's not yet formalized that, but that is the way in which Tamil Nadu Municipal Medical Corporation will slowly start working. Because your procurement agency should be independent of the assessment agency. You cannot have assessment agency and purchasing agency in the same. That is why HTA bodies are sitting outside the health system. They will be independent decision-making bodies within the state health system, but they will not be part of any purchasing unit because you want an independent assessment.
I just have a point again. Why state body?
Can you, if you don't mind, interrupt the fellow reminding me again and again? Let's have a 15-minute break and we resume again.
All right, okay.
Yes, he can continue, and then 15-minute tea break and then 15-minute break. Okay. That's one of the chats.
So that decentralized models work better. But in terms of economics, how do you take into consideration the indirect costs? For example, a person with MDR is not in the hospital and is going back to the family with the risk of infecting the immediate household, right? And you won't be monitoring the people who do manifest, say 5 years down the line, or 2 years down the line, or even 10 years down the line. So that would add to the indirect cost of managing the disease in the short to long term. So how is that incorporated when you are doing the economics of centralized versus a decentralized model?
So it's not just specific to this model, to this particular intervention. When you do, that's why I said that when you're looking at economic evaluation, you're taking economic cost, and when you're taking budget impact, you're taking financial cost. So I have 2 minutes to explain the difference. When I calculate the economic cost and economic evaluation, I calculate 3 things. I calculate what is the direct medical cost. So that essentially means what is the cost on consultation, what is the cost on drugs, what is the cost on, say, laboratory investigations or radiology investigation. That's under the category of direct medical. Then I also go and calculate what is the direct non-medical. The direct non-medical are, for example, food of the patient, travel of the patient in case of support or anything. You also have what is called as, then the third category is indirect cost. Indirect cost basically in our you have 2 methods. One is friction cost method and another is human capital method. I'm not going to the details of that, but what simply put is that there is a wage loss multiplied by the number of days that the person is hospitalized. So you can more or less capture what is the indirect cost for receiving that care. In our cost, when we calculate all the 3. I calculated the travel cost, I calculated the productivity losses, which is basically wage loss multiplied by the number of days, and I calculated the direct cost. So when I incorporated all the costs, and that is important because in a facility, centralized care, the patient will be in the hospital, so there's no travel. When we actually compared all these things, decentralized care was still considered cost effective in terms of the
No, the question was different.
Yeah, my question is a little different. My thing was that you're considering the cost at that particular time frame when the patient is either in the facility or out of it. But how do you say that decentralized is working better? Because the person the person is quarantined when they are in a centralized facility,
so
right?
Decentralized. For the decentralized, I'll capture the travel cost as well.
No.
She means since it's contagious, so
You're talking about infection and all.
Yes, you might actually be adding to the decentralized cost because there might be immediate family members living in close quarters who might manifest.
So there may be adjusted. So that is where we have mentioned, we did the scenario analysis exactly to mention that there will be always some kind of patients who will not be eligible for decentralized care, right? And the other is we did not capture because we did not have the transmission models to actually understand what is the impact of, say, a patient who's at the household and what would be the cost of transmission if that disease happens to another. Unfortunately, we did not get transmission models evidence from there to understand how many people will be infected. So that was a limitation in ours. But in terms of the actual evidence from WHO, and just to tell you that we did a previous study in 2015 in Nigeria using a similar model. And the one that I showed you about the 3 evidence and the systematic review has now been incorporated by WHO as a guidelines for treatment on NDR, which was actually updated in April 2017. So basically what they're saying is there is some limited evidence, not high level of evidence, because a resource constrained environment for MDR TB, because of lack of resources, beds and other things, decentralized care is the only way that you could go, because the evidence is still based on an observational study. There is no randomized control study that was done. So there are some limitations on that. But given the resources and the level of evidence that's currently available, decentralized model is the only way to go. Although there could be reasons where where you need clinical trials and maybe infectious.
Because that's a very important consideration.
I'm not disputing that. But the WHO has considered, if you look at the guidelines of April 2017 of management of MDR TB cases, they have said that these are limitations, that the current evidence doesn't look at this, but given the current level of evidence as it exists, including effectiveness and cost effectiveness, they have said a recommendation has been decentralized care model in resource constrained environment. So the reason that we took India was essentially because of that context. In fact, in Canada also, in certain places where there is resource constraint and they are focused on TB in, say, Inuit populations, they are talking about the same. But there they are not focusing too much on decentralized care because they can still afford a centralized care.
I think this session should have been the beginning, not at the end, but still I have to be little unfair to our gentleman, and I request him to be specific on particularly this air filter technology seems to be very interesting and promising. I want to know how we can increase the affordability and maybe large scale adaptation. What is his suggestion, and how these stakeholders can benefit or they participate in this large scale adaptability, or rather increasing the affordability by reducing the cost? What is his 3 suggestions?
Right. So when I told that 18 months of time being spent on really doing the research to have a physical manifestation which can really use the power of moving air and clean the air, all these challenges has gone into place, making it affordable, making it productive. So the patent research, the patent I'm talking about, the filter currently we have, they use wax technology which make it very fluffy and very large volume it occupied. So what we have, the technology we have made it will come in a block piece which will fit in small polythene bag, and once I open it up, it will still make those air pockets, which is currently done from the conventional technology. Similarly, making this whole filter-based things, talking about making it big molds, which even can cost of 1 crore rupees, we again thought in terms of what technology it can be, so that now we have this piece of plastic which is developed in length. So there is a die in which there is a stretch of wire. So same way we stretch out these plastic pieces, so you get a particular length of 2 or 3 meters, and then we create a block out of it. So on all these small little aspects, how we are going to produce it in much bigger quantity, how it will be manageable, it has to be detachable over the car so that public can get engaged in it. All those process has been thought out, but still there is a research of scope which we still feel is out there, because the filters we have studied deeply, we clearly see that right now it's the pores in the filters which actually clean out PM10, PM maybe 250. So these fibers are itself very thick. So if we can go to the nanofibers, we can clearly see we can reduce the air resistance and still can filter out these particles according to their size. So, but I think we are ready, at least because it's a war-like situation if I see current scenario of the weather. So we have a basic minimum filter technology which can clean outside air and at a very, very low cost, because there is no electricity required. If I talk about 50 lakh such filters and provide mobilization artificially by a motor, by an electric fan, it will cost me Bhakra Nangal Dam to really power it up. So that we are saving it. There is no motor, there is no electric motor, which means there is no maintenance required. So huge amount of logistic challenge is being solved. And by doing it at a petrol pump site, it really solves a lot of issues that how we will manage at the home level, because these vehicles come at that place, recycle of this filter can happen easily over there, and it will convert into employment also. So yes, all these years we have been thinking about very, very detailed process of all these things, what the challenges has been posed out. But more than that, I think so if I can get suggestions from you.
I'll give you a suggestion.
Sure, how we can engage people, become part of this movement, taking this ownership, and more than that, getting aware about the deadliness of the air pollution. Believe me, I have asked so many people, 99% of the people are not aware.
No, I have a suggestion, sorry.
Sure.
Mr. Bhatnagar, I'd suggest the best way to work things like this is do a little subsidy on the petrol. Let the government do a little bit of subsidy on the petrol. You'll get 1 rupee cheap if you have this damn filter on your car. Trust me, it'll work.
So I just want to add this to up. So yes, my thought process is a bit different. I think government is one stakeholder, But as a society, we
Understood.
should not always go to government that they need to solve our issue.
Money works, yeah.
I agree. But more than money, I agree to that. So we went to government. But I see it's such a big elephant. There are 10,000 people poking to it. They don't know who to listen to, right? So I understood that this has to become a movement that even if I go to government first, even if I get the money, I still has to go to public because it's a 50 lakh number which has to get operated by the public. So why not go into the first place? So we started this journey, and the good thing is I saw that very positive impact. We went to Vasant Kunj, local community in the park. You know how they behaved with us? कि अपना टिकड़ा उठा के निकल जाओ यहाँ से. We said अच्छा हमने टिकड़ा साइड पे रख दे. We just want to talk about this. तो हमने उनको बताया कि एयर पोल्यूशन के बारे में बात करने वाले. The moment we talk air pollution, because there was a haziness all around. उस टाइम AQI 300 था वसंत कुंज में. So they started listening to us. When we ended our presentation, everyone came, congratulated to us and said yes, it is going to work, and they start donating it to it. बट मेरे को उसमें जो एक चैलेंजिंग सबसे लगा, एक कर्नल आए, उन्होंने बताया कि यार आप एयर पोल्यूशन के बारे में आपने बहुत ज्यादा बताया, उसके इम्पैक्ट के बारे में वो सबको पता है. देन आई सॉ उस टाइम जब मैंने उस टाइम AQI चेक किया, इट वाज 300 एंड मोस्ट ऑफ देयर वर 400 पीपल इन द पार्क. दे वर डूइंग प्राणायाम, दे वर एक्सरसाइजिंग इट, एंड दे मस्ट नॉट हैव बीन डूइंग इट दैट टाइम. Then I could understood that awareness is actually literally one of the biggest challenge related to air pollution, because जितनी भी death मेरी family में हुई या जो भी premature birth हुए, nobody related it to air pollution. तो जो अब suggestion यानी जो एक it's a very valid suggestion, I'm not disregarding it, but ये है कि जब हम public के पास जाते हैं, I see there is a better response from the government also which comes, because when it becomes a movement, when 10,000 people are talking about it, yes, then response goes out very well. So how to engage people as a part of it? अगर ये suggestion आ पाए, nothing like it.
But what about the automobile industry? Since you are an engineer, you have you done your automobile engineering?
I did mechanical from
mechanical. So I think it would be good to approach the bigger companies and discuss this, because they can make something like streamlined kind of which will look like sports cars, you know. Like
Right.
Everybody buys accessories to make their car look beautiful.
Right.
So
You pay
if
15,000
this can be
for a spoiler
done,
on Honda City.
and
15,000 rupees.
Yeah, it's. I think you should look into
Which is at
those
the
ways where you
side
can
up.
approach the companies, the big companies.
Agreed. So in that sense, when we thought about it, so it is, there will be new cars which will be coming in. So it's per day probably 1,000. But here we are talking about before this winter, this has to become 50 lakh in number. Then only I'm ready to handle it. So yes, so we that is a good idea.
And what about the public transport system?
Yes,
There's
that's
so
your
many
thought.
of them who are giving pollution to the back door, and why can't the buses have it?
Yes, buses, commercial vehicles, Ola,
See,
Uber.
Kejriwal is coughing away to glory. He's the first one should be having it in his car.
That's okay. But first, the most importantly, the filter that you are going to use. You talked about PM10, but the problem is when the particle size goes down, the problem becomes more acute. Yeah. So you mentioned that your filter had 67% of efficiency for PM10. And definitely it will go down when you talk about 2.5 or PM1, which is more of a problem. And as we have moved from petrol or diesel to CNG, the PM particle size in the exhaust has gone down as well.
No, we didn't move. The government made us move.
Of course, that is what I meant. Exactly, and of course you will not be able to move. Only government will make you move.
And we have a long
Lunch break.
That's a very important question. I want to answer that. So when you say that this 60%, 67% efficiency, so it is not the air which is passing through how much particle we have captured. So it is 15 centimeter by 1 meter block. If I take it 100 kilometer, it comes out that 15,000 meter cube air should have passed through it, right? But we actually calculated how much carbon being captured, it related to 10,000 meter cube. So it is the efficiency of air, when I walk it through, how much air actually passes through. But the filter cleans 99% of that PM10. So there is a dust particle which is of the size of 100 micron to 250 micron. We have studied in the microscope. So these are very small carbon particles which are of molecular size. These what we are capturing in the replaceable filter. But the dust which is 200 micron, 250 micron, that is captured in the washable filter, which we can wash it probably in 30-second time. On the petrol pump, the model we have already planned out for that purpose. So efficiency, once the air actually passes through the filter, it is near about 99%. So 67% came out that if I move the vehicle 100 km, it should have been 15,000 meter cube air. Volumetric swept. So out of that, it cleaned 10,000 meter cube. So that is the efficiency we have mentioned about that. Not once the air passes through, it cleans out the whole thing.
No, efficiency of PM10 or below, because the particle below PM10 is the major problem for asthma and
so
all
when
the
we say
problems.
PM10, it actually carries out everything below PM10. So everything less than 10 microns is PM10. Everything below 10 micron is PM10. So PM 2.5 is a part of PM10.
So probably if you can break it down with
Maybe
the particle
I think
the idea of
get
Uber
engaged
now.
during
So
the
Uber is about to
lunch
launch
break
2
also.
lakhs in NCR. They are about to touch 2 lakhs. I mean, you connect with them, 2 lakh cars already will be having.
Help us connecting with them.
I mean, Gurgaon DLF golf course.
I would love to. I
head
mean,
office.
you know, the problem
I
happens.
can connect you with the strategic
right
head
person.
of Uber.
Yes.
Right?
That is good.
I think that's a good idea.
Connecting to the right person is very important.
I know him very well.
I think there's a great thing, convergence that's happening in interest of time of all of us and the target given by Dr. VK. I summarize before I say anything. The last one that I was talking about, the fourth year that reserved for me was the adaptability. This adaptability can make sense only when all of us come together. So I call in my language as well as adapted from academic language is called collaboration, collaboration, collaboration. And collaboration with none other than your competitor. And we are collaborating in our life with our competitor. There is the best collaboration between wife and husband. It's the competition. This is the competition. That you are collaborating with your competitor. Arvind model says train your competitor. If you want to know more about collaboration and and collaboration with your competitor, and that is, I am the collaborator, I am the competitor for all of you, and I am ready to collaborate. I am ready to collaborate with our Bandari ji on waste management through my student. My strength is my students. So right now I am working with the UP Medical Supply Council. At least about 15 students are working on different topics and developing the systems and processes for implementing Tamil Nadu model in UP. So my biggest strength is my students. So I am ready, I am here to come with any of you or all of you. That is the reason why I am here with Dr. VK. Dr. VK platform is the biggest platform for me, satellite launching platform for me. So this is Dr. VK's platform. I am shamelessly and honestly I can share, and we owe everything for Dr. VK. I am not saying. And
Thank you very much.
And I fondly call him as People's Doctor. I could see that People's Doctor news item today. I already shared that on WhatsApp. Please create a WhatsApp for this entire and that is one. And I want to just, I'm basically an academician, just let me share academic knowledge on this. Next 2 minutes I will close. So my collaboration with him, I want to donate a few filters for myself as well as for the school that I am working with, and also have a petrol pump of my friend who is doing this at Tirupati. So I will discuss with him how to take it forward and put it in the couple of locations and see whether there is a possibility of taking it up further. So CII is another very big platform for collaboration, and we are working with CII, and CII can come, and our Dr. VK Saab is the CII health member, so this can help in a big way, and the actions should speak rather than speaking here. So now my request, Dr. VK, is that last workshop also happened something, and this workshop also is going to happen something. What are the actions that we have taken? How these actions can make the difference? I think this startup is not an ordinary startup. This is the action-oriented startup. So I request Dr. VK startup to take up what are the actions and how to make these actions on time-bound actions. And coming to my action is that we have, I'm also, it's not a marketing, I'm not a marketer for that matter. I am operations management professor at IIM Lucknow, and the first time in the history of 60 years of IIM system, we have taken this course, Healthcare Operations Management, as a formal course for our students. There are courses, executive development programs, etc., business, money making. IIMs means you want to talk to IIM, you have to pay and talk. Here IIM is talking to you without paying. So please take it. It's a reverse model that I am bringing it. So you want to talk to IIM, you have to pay and talk. Whereas IIM is talking to you with free, or for free rather. So please come forward and do it. I want to do this time course, and I am happy to share with all of you that 120 students, I have stopped it. 2 sections of 60 students have taken this healthcare operations management course. After seeing this first launch at IIM Lucknow, IIM Udaipur, IIM Jammu, IIM Sirmaur. And IIM Sirmaur course was started by Dr. VK, and IIM Jammu course in between was special session was handled by his partner, business partner, Mr. Sachin. And the IIM Lucknow students were engaged by Dr. Armugam, who was the architect of Tamil Nadu model. So next time, when I want to start this course with a round table of 1-day round table, Dr. VK is going to be there, Mr. Bandari is going to be there, Mr. Denny is going to be there, Mr. Bandari is going to be, the partner is also going to be there, many more people also going to be there. John Hopkinson University has also approached us by looking at what we are doing. So I want to have a special way of taking this course forward. So help us to do this better for part of health of everybody. So the business models have changed, capex to opex, opex to pay as you use, now pay as you wish. We have a Keralite here. Canteen is started. The Communist Party has started pay as you wish restaurant model. So health should also be pay as you wish. So these kits can be sold more pay as you wish. So that is one of the models that we can take. So with this, I'll stop here, and thank you so much for everyone on behalf of my personal as well as Dr. VK's personal behalf. I think lunch is waiting. Thank you once again. Thank you.